we have with us now Teresa Judd from Ontario Home or Ontario Health at Home. I am going to say that wrong. I am so sorry. The name has changed too many times for me. As we're moving forward right now, the goal of the whole afternoon piece, so Teresa, myself, and Janet and Teresa. Yes, we have two Teresas. The whole concept this afternoon is to bring more resources to you. So you will be resource loaded by the time you leave today. We're just hoping that we're providing information to let you know that you are truly supported. I love when, Teresa had mentioned before, reach out to your local pharmacist, reach out for those reviews and whatnot. I think sometimes we, as professionals in general, work in siloed workshops, right? Like work in siloed pieces. And it's really nice to know that there are other supports out there that we can avail of. So, Teresa Judd joined the Ontario Health at Home, formerly known as the PLCCAC, at at the time, in a care coordinator role and moved through many different roles as an education lead for the launch of the RAI-HC and the RAI palliative assessment tools. She managed the intake team during the home care transition of 2007 of 42 regions down to 21. Remember those days? I do. I was here too. In 2012, she became the regional lead for the Central West Behavior Support Network under, under the Behavior Support Ontario, or BSO, provincial model. Her passion and support for the developmental sector grew as the chair for the Central Region Partners in Aging and Developmental Disabilities table. That's the committee that's bringing you this work today. She has over 20 years of experience as a registered nurse and leader within the healthcare sector in the areas of acute care, long-term care, and community nursing. Her passion for supporting seniors and older adults has continued as the past provincial co-chair of the BSO Integrated Transition Team Collaborative. She was responsible for the co-development of My Transitional Care Plan, a tool on the Brain Exchange website, and a tool, I have to say, many of us use often. She continues to develop innovative solutions working with recreation therapy staff in long-term care homes and draws upon her many personal and professional experiences in supporting person-centered outcomes for patients and their families throughout the Central West and Mississauga-Halton geographies. Leading placement services, the BSO community nurses and community pharmacists programs have created synergies to better manage complex patient and family situations. Welcome, Teresa, and I know you will love this presentation, everyone. Thank you.
Thank you. So I felt it was important to give you a bit of my history because I think I've been in the system long enough, and so I've seen it. It looks different every time, but it's different players, but sometimes it's the same scenarios, but never fails to surprise. And I always love the increased complexity of supporting the developmental sector. It's fascinating, and I think it's a great opportunity for us to grow and become stronger partners. So I'm providing an overview today about Ontario Health at Home, formerly CCAC, formerly Home and Community Care Support Services, formerly the LIN, just to clarify that. So please refer to us if you can remember anything. Ontario Health at Home, OHAH, OHA. If that can help you, that would be fantastic. So where I want to start today is really to provide us some overview. We have some learning objectives here just to gain a general understanding, trying not to let you go to sleep, but I want this to be an engaged conversation. If you have questions, please pepper them throughout the presentation. That's how we can all stay awake and alert after the carbs. But also, this is a learning opportunity because I think people have preconceived ideas or assumptions around what we do. And our services have changed seriously over the years as we've come together in the past 2 years as one full organization across the province. So this is important around the standardization and specialization of the services we provide. So what do? We provide services in home, in the community, We support specialized programs, which we'll speak a bit to, palliative care. We are in the hospitals, we're in the schools, and my personal portfolio really focuses on long-term care application admission into that facilities. Okay, so we are Ontario Health at Home, and we're here to serve every person in Ontario. We partner with patients, caregivers, primary care providers, hospital, long-term care and retirement homes, service providers, and newly and ongoing will be Ontario Health teams. And some of you may be part of that or learning more about that in terms of some of the leading projects that may have been launched in your specific geography. So, what else do we do? Well, we support over 651,000 people a year, and this is a considerable amount of individuals. And every month, care coordinators collectively have over 344,560 active patients on their caseload, and that is a lot. And it keeps us very busy. And I can tell you, in the early days when I started as a care coordinator, we had 10,000 active patients in our one geography alone. So you can appreciate the size and magnitude. So looking at the numbers here, we have over 27,000 nursing visits. We provide 4,200 therapy visits and over 100,000 PSW service hours every single day. That is a lot of people, and that is a tremendous workforce that we reach out to and working with all our community partners. Transitions, over 28,000 patients move into long-term care annually, and we administer 1.2 million patient visits at nursing clinics. And this is a new and developing area. A lot of people think that services are just provided in home, and we'll speak to that today about nursing clinics. Contract services from over 100 service providers organizationally, and this is really neat because some of these particular providers cross over in many different geographies, and you have experienced them, and this is the great uniqueness of having the synergy together. Okay, so next slide here. And so where do we apply our support and help? We help patients and families. We guide those patients and families and caregivers where they need service, support, and guidance. In most importantly, it will help remain in the safety of their own home with the necessary supports and other care professionals that can keep them there within reasonable means. We also recognize that transition is a significant part of our work, and that may be to move to a new location, long-term care or supportive housing, can also be to help align with adult day programs, retirement homes, and whatnot, where that individual best can have their needs met. We leave the hospital and we recover at home. We avoid visiting the emergency department. We are a very large initiative provincially around our business continuity to ensure that we really keep people out of the emergency department or to return them to home as fast as possible if they have had an episodic visit to the emerge. We really pride ourselves around to die with dignity and the setting of that individual's choice. Help support and find doctors or nurses as a practitioner, and also find community services that support healthy, independent living. And just as a side conversation, the work that Dr. Pitfield is leading right now provincially around care connectors in the province is leading important work that I'm sure you'll hear more about getting individuals connected to primary care physicians and practitioners. Okay.
And Teresa, just sorry to interrupt. I do have a question here from one of the participants today.
Sure.
If an individual lives in a group home and is discharged from hospital, but needs extra support, would Health at Home help provide that extra care? This is why we wanted to present this content today. Take it away, Teresa.
Yes. So we pride ourselves on partnering with our group homes in this particular sector. What we do need to always make sure, no matter where that individual is going, is that it's followed up with an assessment, and I will talk to that around eligibility as well. We always want to know what is in place right now or what has not been leveraged. These are critical things. I'm going to speak to it more, but I will tell you absolutely we will partner. And it's really also about recognizing what is provided right now in terms of that individual's care needs. Do they need nursing services? Has there been a change in their clinical composition of their care plan? And that's where we can most help and support. So I will answer your question more thoroughly. I hope that has a good start to get you going there. Thank you for the question. So home and community care eligibility is they need to have a valid Ontario Health Insurance Plan or OHIP card number, and their healthcare needs cannot be met on an outpatient basis. So if they want services in their home, then this is something that we will do in terms of our assessment. This is why we also look at clinics. If the individual can go to a clinic and requires a nursing service, then we will leverage that as well. A need for at least one professional or personal support services. And we'll talk about the referral process as well. Anybody can refer. It doesn't have to be a physician, but it does help if there is a clinical basis to that referral where a medical condition is required. Having more context or understanding what that treatment is required coming from a clinician is absolutely helpful to round out the care plan. Okay. So care coordination, and some of you may have heard of that. Can I ask, have any of you experienced that with any of your residents or your clients? Support for care coordination? Maybe if you just do a show of hands, that would be great. Do you know what care coordination is?
Oh, you got one thumbs up.
One thumb. Well, I'll take one. One is better than none. And that's why
Two. It's climbing. Three.
good. Okay. I'm glad. I
Four.
wanted to have it do that. Okay,
So
that's
some.
oops. Oops. Now
Some, but interestingly, you didn't get 60.
I know, and that's
Thing,
what I'm
right?
here. So
Yeah.
the premise is to really understand what is care coordination. So these are regulated individuals that come from a variety of backgrounds. They could be PT, OT, nursing, SLP, respiratory, even registered psychology. So we don't see a lot of those in our profession, but we do see primarily nurses make up the largest section of healthcare professionals that provide home and community care services. We visit patients in their home where they're at, in the hospital, or also in the school environment. So the home could be the community. It could be long-term care. It could be a retirement home, could be assisted living. So home has a pretty broad term. And just to let you know, the important part is that we really want to reinforce the importance of its needs-based. We want to understand what does that resident, patient, or client really require to keep them safe and sustainable in their current environment without having an ED transfer. We evaluate each person's care needs and develop a customized care plan. And we always want to really focus on contingency. So when we develop that care plan, and this is a perfect example in our developmental sector, is that we want to know what contingency is. So if that PSW doesn't show up or that nursing agency doesn't show up as anticipated by the family or the provider, it could be not necessarily be a family member, is that we want to know what's the alternative if that individual does not show up. And we will be able to socialize that with the care team. So we also coordinated services that look at the most appropriate levels of care to promote the rehabilitation and the independence of the individual. So what are our services? Well, we have in-home, in the community, specialized, in-hospital, child and youth, and long-term care placement and palliative. Home and community care services may include care coordination only. It is rare that we provide just care coordination, but it does happen when we have a comprehensive care plan that the family can stand up, or we have other means of family directed care. Nursing, personal support, we have OT and PT, speech and language, social work, and dietetics. Any questions at this time? Happy to keep going. Okay, so in the community, when we look at community-based services, we will assist and support in navigating individuals around meal delivery services, friendly visiting, transportation services, adult day, helping to liaise and refer in different areas. There are different models of adult day programs in each geography across the province, links to care, and then also looking at more comprehensive support in assisted living. This could also mean group homes, right? Congregate settings, retirement home, short stay respite, long-term care home, retirement, and then also when long-term care community options have been exhausted and that individual is requiring more services, we will certainly look at how we can help support. Okay. So in the community are community nursing clinics. So I didn't even know this. This always surprises me when I get this information too. We have over 140 community nursing clinics providing free, provided you have an OHIP card, high quality specialized nursing care. And they are booked by appointment only. And we do have, in many circumstances across the province, extended operating hours on the weekends or through the evening. Um, if we are unable to accommodate the individual nursing clinics, then by exception, we have gone to people's office spaces to provide treatment if needed. And we try to be able to support and serve our patients where they best can be served. Okay. So home and community care options around specialized programs. So we have home care nursing, and this is I would say this program is more strongly identified in the GTA area. We do see this in our rural programs up in the north and the northeast and northwest, and this helps people living with congestive heart failure and chronic obstructive pulmonary disease, COPD, to achieve their best quality of life. It helps patients manage their controls, and so they're getting remote monitoring, which means they are often observed through data or digital feedback that the individual in the home is pushing all the time to the service provider, the nursing agency, to help monitor their overall clinical status. And then there are algorithms or there's targets if that individual is not meeting them, and which we would involving more regular health coaching sessions or the involvement of a nurse going out to actually see the individual. In many cases, our telehome care program is often supported by PSWs that have additional advanced training to help support in this monitoring. And they are excellent in terms of the front line to be able to relay messages to the telehome care nurses if they see a physical change in the individual that might not be picked up in terms of the monitoring process. Palliative nurse practitioners. We have a very robust team, and I'm speaking more around Central West and Mississauga, Halton, and Wellington, Waterloo. What we do know is that they support life-limiting illnesses. They will help navigate for those individuals that are interested in MAID, which is medical assistance in dying, but we actually have separate external teams and providers that help support that particular process if individuals are interested. We have advanced clinical assessment and diagnosis. They work very closely as a team and usually have an extended reach into primary care or other specialists through oncology and palliative care physicians to help support the ordering of labs, diagnostic tests, the medication prescribing, medication management. And I will tell you that our palliative nurse practitioners works very closely with our in-home pharmacy program in Central West, as well as our community partners like Shoppers Drug Mart, Rexall, any of the other community pharmacists to really make sure we're getting the right mix of medications and do optimal pain and symptom management. So what does coordinated connected care look like to you? Any thoughts on that, folks? I'm interested in your feedback. Just maybe you can pop a few things in the chat for Paula. What does coordinated connected care look like to you, or have you experienced?
One comment is booking self-reflection at the end of, oh, wait. That looks like it's gone back. Just a sec. Oh, no. Just wait.
You think about connected care. What does that mean?
Seamless care.
Seamless care, yeah.
Is one comment.
I'm sorry, my chat is disabled. I haven't been able to use it.
Okay.
I don't know why. So
speak freely.
Speak freely. That's right. Who are we talking to?
Oh, hi, I'm Tina.
Okay, go ahead. Tina.
I work with a lot of care coordinators who are coordinating even just day programs to daily living at the group home, or for even independent supported living in that area. Dealing with, hospitals are really important, navigating medical visits, appointments, testing, which we're waiting for. I'm hoping that moves a little faster in the future.
Okay.
Yeah.
That's
A lot.
excellent.
Great examples.
And
Good.
I've got Kim. Kim has her raised hand there, and I like these comments coming in. Working together collectively to deliver effective, appropriate services. I think that's absolutely paramount. And as far as the slides, honestly, so there was another question here, Teresa, but will these slides be available for distribution? And this is one slide deck that we cannot share because it is actually property of Ontario Health at Home. Well, I
Yeah.
did it right, Ontario Health at Home. So
Happy to
we'll provide links.
Yes. Yeah. Well, I'm happily to expand if you had some particular areas. I'll tell you why it's not being shared. It's because there is data points in here that they change. And so we're concerned about having that data when it changes. And we refresh this deck very regularly. So we just don't want to have stalemated information out there. But I would tell you, please reach out to myself or any member. And I put the link in there for our website. And just because this one was for Mississauga Halton or Central West, you can navigate right on that site to find your particular geography and happily reach out to get more accurate, updated information.
Okay, I hope that helps. And yes, I think you will be certainly left with all of the supportive content that you need by these links. Okay, let's see here. Connection between individuals and extra supports in health and community. And you've got two more comments here from our fine people entering in the chat. My family has a doctor, PSW nurse, pharmacy, and OT all coming into their home daily on a weekly basis. And they're very grateful for Ontario Health at Home for being able to coordinate those wonderful services coming into their home. I agree. I echo that. And it's just so nice to know that they're available for all of the people that we support. And Janvier then, collection of various community partners, or collaboration, sorry, with various community partners. Collaborative healthcare is definitely what everyone needs to wrap around them, isn't it?
Exactly.
And last one then for right now, would an individual support plan for persons supported part of coordinated connected care? Just wait. Would an individual support plan, an ISP, for people supported in a home setting be part of coordinated connected care?
So I think it would be part of that. Ontario Health at Home, we have our own kind of care plan, which we would share as a contingency and also to make sure that the partners around are supported so you know what they look like. But your contribution around their individual support plan will be really instrumental to make sure that we're holistic and that we're really understanding where that particular resident is at in their care journey. So we would welcome that sharing, absolutely. And that would best be achieved by having care conferences or a clinical conversation or huddle with the team to make sure that we're getting the right service level. Does that answer your question? Maybe a thumbs up will be helpful.
Yes, it does. Thank you.
Okay, great. Perfect. Good.
Excellent.
Okay, so can I move on, Paula? Okay, so what does our palliative care team look like? So we look at supporting pain and symptom management in the home, which they call home, and where they want to die. Some individuals choose to die in their personal home, but we can also support referrals into our hospices in the community through care coordination. And also individuals may also want to be admitted to long-term care where each long-term care home can provide palliative care supports, typically for older individuals. Because as you know, sometimes when you wrap a palliative care team around someone, they actually get better or become more stabilized. And hospices have a limited, I would have to say this, a best before date. And so if the individual exceeds their length of stay in a hospice, you may want to consider looking at alternatives to remain in their home as long as possible or to have them transition to a long-term care home or retirement home setting. Okay, so in the hospital, a care coordinator partners with the hospital staff. They will do your assessment there. Often, what happens is individuals leave the hospital before we're able to actually physically see them in person. We are aiming always to see as many as we can, but sometimes, if it's a quick turnaround, particularly in the emergency department, care coordination is challenged by the multiple people that we have coming in to be able to follow up. So, always a really great opportunity. Each of our hospitals in the GTA area have the equivalent of what's called a GEM nurse, which is a geriatric emergency medical nurse. And these are individuals that I would strongly recommend that you reach out to the emergency department. Someone is coming in. Our population in the developmental center often have a very complex care plan involved, particularly as they're aging. And it would be best to be able to give advance notice to help support that transition and preparedness for the staff in the emergency department, as well as being able to have care coordination part of that process. So we can turn them around quickly without seeing decompensation happening in the emergency department or hallway medicine, which I'm sure you're familiar with, to have them return.
I have a question, Teresa, just when you said the GEM nurses.
Yes.
So is that only age indicated, or you
Yes,
said
for
you
older
mentioned
adults, yes.
complexities? So if you have a person though who has an IDD, and let's say they're 50, so they might not qualify as an older adult, but physiologically they're looking more like 70.
Yes.
So if one of the workers has to take somebody to the hospital, could they request a GEM nurse and just kind of make that piece known so that
Flag.
they're getting?
It's always great to flag. And if the person is on Ontario Health at Home Services, let
Yeah.
that care coordinator know, because then we have mechanisms internally to connect with our Ontario Home Health staff in the emergency department. So
Okay.
that really can mitigate a lot of risk, as well as looking at more seamlessness and turning that ED visit around quickly. We want individuals to go to the ED if that's where they need to be. But if we can contact the Ontario Health at Home care coordinator, then maybe we might be able to spin around very quickly and have a nursing agency come out and visit for assessment that could prevent an unnecessary hospitalization.
Right, or unnecessary, transport back and forth and all of
Absolutely.
that can be really difficult. Okay,
Yeah.
I think that's really, really good for people to know too. Thanks, Teresa.
Yeah, no worries. So when we also look at those individuals that may have had particularly cardiac related issues, or there has been a prolonged hospitalization, it's typically in our older, but we do see in our younger population, recognize that the rapid response nurses are a quick follow-up immediately after hospital discharge. We have very tight timelines that we have to see that individual usually within 48 to 72 hours. And we will visit them on the weekend if need be, if they came out of hospital on the Friday, provided their care plan warranted that they need that urgency to be seen by a nurse. And what they will do is help mitigate high-risk patients from avoiding a readmission. We don't want you to have to turn around and come back in. And also ensure that there are follow-ups appointments that are scheduled with specialists or primary care physicians. Even pharmacy, make sure that medications are filled at the pharmacist. This is often an area we see in our compromised populations that are vulnerable, not just older, that really have difficulty getting those prescriptions filled. And if they can be sent from the emergency department or even from the inpatient floor to that pharmacist, that's a really great option to consider. Okay. So we also want to consider child and youth support. So our coordinators also help this part of our sector, looking at extra care to help support and thrive in school. We have nursing and dietetics that will go into our public schools, and we have alignment with all public and Catholic schools in your select geographical areas. We work very closely with the school boards and also with our private schools as well. We want to make sure that they have access to occupational therapy, physio, etc., actually right in the school where needed, as well as in the home environment. We do support a fairly large population of medically fragile individuals, babies and young children, toddlers under the age of 21, to keep them safely at home, that may be discharged from our tertiary care centers, sick kids, where there is pediatric centers of excellence, and we work very closely to help robustly develop care plans with them. We also have what's called mental health and addiction nurses. We call them man nurses. Not that many of them are men, but they are man mental health. And so they will go and directly work with the individual in the school as well as in the home if need to be to help support particularly youth at high risk of suicide or there are other substance abuse related issues to be able to make sure that they can tie the importance of school with the importance of good holistic health. And so we've had very good success with this particular population. Children and youth, there we go. Mental health and addictions. I'm getting ahead of myself here, but this will provide you an overview. We connect with students and services. We collaborate, the medication reconciliation, and really importantly, recognize when that youth is able to be transitioned back to school from hospital or even in their home. They may be vulnerable and they just need some more time to be supported in their home before they come back, readiness for school. So when living independently is no longer possible, our care coordinator will look at other alternatives to help support the individual where they're at in their care needs. Supportive housing, assisted living, retirement homes, and we should also be adding congregate settings because it's important here that we recognize there's a fair number of individuals in the developmental sector that age in place. And that is difficult for them to continue to remain in that environment. And we may need to look at transitioning to a long-term care home. We really try to keep them with their population because that's what they know. They have aged in place, but we also recognize that in order for individuals on the wait list, we do need to be able to help support individuals moving to different care settings so that we can support lesser care needed patients in those areas.
Well, Teresa, this is making me think of another question. I'm very sorry to interrupt. If your care is your care coordinator still your care coordinator even once you've kind of crossed the threshold to long-term care? My question is, a person that I saw last week is now in long-term care and the team is really struggling that this is probably not the correct, I'm going to say, or best situation for this person. He's only 35 years old and the person themselves is struggling with this transition. Does the team go back to the care coordinator to see if there are any other options, or once you've made it to long-term care, is that kind of it for the options?
So we'll talk when we get to the long-term care section, but to help give you a little bit of a nugget. So what we do is if individuals have been admitted to long-term care, we want our community care coordinators to stay in the community. And then we have what's called placement facilitators or placement coordinators. And so they have the best sight around the file and the management of that individual in the long-term care homes. So there would be definitely a liaising. If it's not a good transition, by all means, we would either pull that long-term care or the community care coordinator back into the mix to support, or there may be a new care coordinator for that geographical area. Because if they moved, say they were in Wellington, Waterloo, and they moved into Brampton, it would not be helpful to have that Wellington, Waterloo care coordinator be transitioning and supporting. There could be some liaising if they went back to that geography, but we would have a Brampton care coordinator through Central West to be able to help support the transition plan.
Okay, so they're not on their own. That's the thing,
No,
right?
they are always
Can have
connected.
different-
And even
Perfect.
if the file is closed and that person decided to be a permanent admission into that long-term care home, we
Mhm.
always can open the file up and align them with a new active coordinator to help support.
Okay, thank you.
It's never closed. Yeah. Okay, so we will look at discussing long-term care options wherever that person is in their health journey, what their care needs. We have a variety of programs that we can support, trying to build on the least touch. So to keeping and supporting independence and autonomy, have individuals either respite programs to give that family a break, that caregiver burden, also addressing the opportunity to consider adult day programs. And I know that each sector also has specific programs. We work really closely with the ABI programs, acquired brain injury. We have some mental health adult day programs across the province. Not all geographies have these particular programs, but we work to help refer and align. We can also arrange convalescent care or restore programs. These are rehabilitation based that are in long-term care that will provide up to 90 days of continuous support for that individual to meet their goals of care prior to discharge back to the community. They cannot stay in that long-term care home. They need to be going back to the community or another community setting if it's not their home. And then, of course, arrange for respite care that's in long-term care, or provide and navigate families to other pay or private pay for service short stay respite programs. Okay. So long-term care, we have over 624 long-term care homes in the province of Ontario. We support over 80,000 long-term care beds. That's an incredible amount. And I can tell you in the immediate GT area between Mississauga, Halton, Central West, and Wellington, Waterloo, that I know that there's about 10 new homes that are going to be launched and built in the next 2 to 3 years. So we have a tremendous amount of beds coming online. And it can't come fast enough, quite honestly. It really can't. They are all licensed and funded by the Ministry of Long-Term Care, and they are all governed by the legislated standards and inspected annually or more regularly based on the needs of the home, or if there is particular incidents. We often have inspections go in to check out. There is a complete guide on I was going to say the connection, but it's also on our website for Mississauga, Halton, or whatever geography you're in, Wellington, Waterloo, and you can find a guide to placement in long-term care homes. And this provides really critical, really comprehensive information to help families navigate, and also to look at their bed readiness. One of the critical things as a key takeaway I'd like to share with you is the importance of being bed ready. So I would need to do a serious myth debust here, is that it's not appropriate for individuals just to go on the wait list because it's a very long wait list and they're waiting. We are really closely monitoring the amount of refusals that we have. We do not have the capacity in the system to consider refusals. We take this very seriously. We will re-counsel the families and or the providers to make sure that we optimize bed admission. Beds do not come up quickly. In many of our desirable homes across many of these geographies, it is more than a 5-year bed wait for a basic accommodation for male or female. And if you have a secure component where that individual exit seeks or wandering off the unit, then they could be waiting longer. So that is just for a general wait list. If we're looking for an expedited or priority access, that would be reassessed. And at the discretion of Ontario Health at Home, we would make them a priority for crisis admission. But I will tell you, in any one of our geographies, many of our desirable homes, there are probably more than 50 to 100 people already waiting as crisis. So the importance here, the message is, don't come on the wait list until they truly are ready to be admitted to long-term care. Okay. And we can take other questions as we head through the rest of the presentation. What is provided in long-term care? So when they can no longer live independently, we have nursing and personal care. They are regularly seen and monitored 24-hour access to a physician or a nurse practitioner in a long-term care home. They are overseen by the treatment, medication administration, and reconciliation of medications. There is usually a pharmacist or a pharmacist group that is attached to that particular long-term care home. There's pastoral services. We look at supporting a robust activities of daily living. There's 24-hour supervision. Although we often hear this person needs 24-hour long-term care support, please keep in mind that under Fixing the Long-Term Care Home Act regulations, that this hours of service that are actually directly provided to a resident in long-term care can be between 3 and 4 hours of direct care per day. So they are in the hospice of managing a 24-hour supervision, but the direct care that they get may only be 3 to 4 hours per day. So it's important to keep in mind because we often hear from families, I need 24-hour care. What does 24-hour care mean to that person? It doesn't mean that somebody is going to be with them every minute of the day. It means that they have access to those services throughout the day, and that there's always that 24-hour observation or supervision. Room and board includes their laundry services, special diets, and also it helps support around the fitting or the appropriateness of mobility equipment as well. We have ADP that can be authorizers that can come in and help support the appropriate equipment for the individual in the long-term care home, but that will be a cost to the individual. Okay, and my favorite is around social and recreation programs, how to build that out to make sure that we have people that are engaged, have meaningful relationships and quality of life in long-term care. And this is part of that supervision. They may participate in recreational therapy programs, but they're not actually getting direct care like we would see in nursing or PSW. Okay, so applying for long-term care, and if you go on one of the websites, which I think Paula has put in the chat, or she can share that out, certainly is your first start. I would really recommend, as a first rung of anyone applying to go to long-term care, is have families or individuals please go and visit long-term care before they say I'm ready to start the process, because that's what we will tell you to do. I need you to go. I need Paula to go out and tour because she wants to find the best possible long-term care home for her family member. And it's great if Paula's already gone out. She's got a taste of what's out there, what she likes, dislikes, and also knows her individual loved one's preferences. And we really pride ourselves on making sure that some homes need to be smaller for some people. Some homes need to be bigger. Some people like loud and busy homes. Other people like quiet, subdued, and maybe more established homes. The other myth I will debunk is that new homes that are shiny and pretty are not always the best options for individuals that have high care needs with behavioral profiles, simply because a quieter, more established home with experienced, seasoned staff may be a much better option to acclimate or transition into that home quicker, and also to pick up other things than having many new individuals that are trying to adjust to the ebb and flow of a new home. That's kind of these are some key messages. I'm trying to give you some opportunities here to leverage when you're helping to counsel families and work with them. Okay, so the long-term care accommodation charges rather. So there is a copayment in long-term care. The accommodation is, you're paying for the accommodation. The care is being paid for by the Ministry of Long-Term Care. So this also speaks to why you see very high fees associated with retirement homes. That is a tenant practice, in long-term, and Ontario Health at Home does not manage the wait list for retirement homes. We only manage the wait list for long-term care. We can help navigate you to retirement homes of your preference, but keep in mind the average cost for, I would say, a middle-range retirement home is in the range of $5,000 to $7,000 per month. Long-term care, for a private room, you're looking at $2,900 a month. For a basic, probably $23. And we also have them graded based on the age of the home. Every year, July 1st, the accommodation rates go up a small percentage across the whole province, because it's one fee for whether it's basic, semi-private, or private rooms. And so we just tell families that at time of admission, you can expect, like the cost of living, accommodation does go up a little bit every year to manage the overhaul in the homes. Rate reduction is not available for semi-private or private rooms. So these are individuals that we cannot decline access to anyone in Ontario a bed to long-term care, provided they have OHIP, right? Because they do not meet the threshold to cover the cost of a basic accommodation. This is why we have a rate reduction. And what we do is we look at their CPP, their ODSP, if they have that, or their old age security. And then the home has an algorithm, form mechanism to help look at what is the most appropriate rate for that individual to pay. Okay, but they have to have an OHIP card number. Okay. So How do you get in touch with us? Well, we're here to help. This is our standard 310-222 number across the province. We're open 8:30 a.m. to 8:30 p.m. We do work after hours, and there is on call. But if you need to get a live person, this is the best time to reach out. Some of our areas are open at 8 a.m. and some work to 9 p.m. But generally speaking, we are 8:30 to 8:30. Okay. Don't be afraid just to pick up the phone. We also have an information and referral. If you're not ready to make a referral for your individual person in the care area, you can even just call us and ask some questions and we can connect you. I will also share with you on the websites now, there is a launched area. If you want to find out more information about a long-term care home, you can reach out and ask for some information to send back to you. You just have to fill out the prompts and then you'll be able to get that information in your geographical area. Okay. Community resources. This is the best kept secret. And I tell everybody, people in the grocery store, when I go shopping or whatever, and they tell me about their problems, sometimes people recognize me. I don't know why, but they say, oh, what am I going to do for my mom? People in my church, people on the street. And I tell them, you need to know about the healthline.ca. It is kind of your best look at what is across the province. You can see here that there are 14 geographical areas. You can click on your desired area. It'll take you right into that geography, and you can search for your community services in your region. You can search by topic, geographical area, keyword search, news and events. Provincial database has over 50,000 services. And it'll also show you across different geographies too. You can compare, and it also comes in French. It is more than senior accessible. The font can be made bigger, which is really nice if you have somebody who has difficulty with reading. Please put this in your bookmarks in your phone. Tell people it is good not just for our sector, for the developmental sector, but for anybody 0 to 100 plus. Okay. And then these are other resources. You can type in Ontario Health at home.ca. That will get you to our centralized website, and you'll be able to navigate to find your right geographical area right up at the top there. There's a little search screen area, and you can fill in the area that you are looking for in terms of resources. And I think, listening to the people we serve. Okay, so most importantly, we're committed to listening and learning from your experience. We also have a community engagement program, which I've been very involved around caregiver burden and distress. And every year we have an annual, award ceremony for those patients and families that have demonstrated outstanding leadership around caregiver supports. So we honor our families and providers that have done an exceptional job. We have care coordinators, or you can reach out directly to our program on our website to nominate someone in our caregiver engagement program. And it's wonderful because usually those that have been involved and have been awarded, we send them out a special journal that they can continue to journal for their loved one. And we usually send out, and I just happen to have this beautiful little box of Purdy's chocolates goes to each and every person that has been nominated to be part of this engagement process. So it's really great. Families love it, and they get to share. If you go on our provincial website, you can actually see videos of past years. This past year we had in April, which is Caregiver Day, April 3rd, I think it was. And you can actually see how we celebrate their contributions. Okay, and then you can join. This is just a little bit more. If you want to be an advisor to participate in this caregiver, and we look at all different populations. I think we are really under supported in the developmental sector. So if you have a willingness, desire to want to contribute, and you have more than 5 years of community care experience, then I would strongly recommend put your name forward. We would be happy to have you participate and support as one of our advisors. Okay, I'm done talking. I probably blew through that rather quickly.
It was excellent, Teresa. Absolutely excellent. And we've got one of the participants, Christina, has given you an applause symbol in the chat. There's just so much to know. And I can't even imagine that your brain holds so much, Teresa. Absolutely. But it's really nice to know that all of these things that we have known are available for the medical sector are also there to support all of the people in Ontario, the people supported in the social services and children's social services sector too.
I have to put a good plug in, and I didn't give good acknowledgement that the support for the Behavior Supports Ontario program is actually peppered throughout all of our sectors. So we have good behavior support people in the community, in long-term care and in the hospitals now, often in the emergency department or on the units that help through elder care supports, as well as behavioral interventionists. So I would also say that in your geographical area, if you see an imminent transition going to hospital, please reach out to the hospital and ask, do they have a behavior interventionist attached to BSO? Because I recognize the developmental sector, individuals do not do well staying in hospital. They are best supported and managed in their own community and around the people they feel comfortable with, and know them best. So please try to reach out, keep that in front of mind, if you are faced with a transition for one of your residents, clients. Okay.
Excellent program. Yes.
Any questions? I'm happy. I think, do we have a bit of time or
Yeah, absolutely. Absolutely. Yep. Much
I
time
don't
as
have a
you need.
question, but I want to make a comment, Teresa. We, as a personal family, received great service from Ontario Health at Home. It wasn't called that yet. We were still in the old days of home care. But my husband was just mentioning the other day, he got stabilized. The PSWs were removed from the home. Obviously, they needed to give care elsewhere. What I don't think gets recognized is that the PSWs give psychological support as well as physical support. And they were excellent with him, and he really misses them. I just want to recognize that everybody that we engage with, and we were engaged for a long months and months and months of care, everybody that we were engaged with really wanted to do their very best. And so don't let reputation put you off. Sometimes people say it's a big organization and they don't get to know you. I would say that's not true. Reach out. We had an excellent experience.
Wonderful. That's great. Thank you for sharing, Robin. The other thing I did want to share is just around there was legislation passed in the last 5 years regarding individuals, particularly if they were having a behavior plan and PSWs were supporting in the community. So that individual is being transitioned to long-term care, and it's in a reasonable geographical area. So if they are staying in the same geographical area, we will do whatever we can to help liaise and support with that PSW agency to help transition them into long-term care. So we have mechanisms in place. It would be short-lived. It would only be for a few days. However, it is an option I wanted to make you aware of, because that transition alone is difficult. And if you are having staff leave your congregate setting or the community where you're supporting, for one of them to be able to go with that individual could be very trying. But if you do have a PSW that has been consistent, knows that individual, we can certainly leverage this as an option where possible. Parties have to be agreeable to have the provider available to do that. But it is an option, and we need to consider, and I just wanted you to be aware of that.
Wow. Speak about seamless care. That's amazing. Okay. And Elaine put in a comment for you, Teresa. Great information. You're a fountain of knowledge. I always learn something new from you. So thank you.
Thank you very much. Appreciate it.
Okay. Any other questions, folks? You can just unmute yourselves and ask, or throw it into the chat. We know you've benefited from this fabulous presentation, so thank you. I will let Andrea thank you at the end with everybody, okay?
Are we tight for time? Do we have a few more minutes?
Yeah, we have a few more minutes,
Okay.
and then we're just going to take a little break.
I could actually show you the website, if that would be helpful.
Yes,
to
please.
help people navigate where they might be looking for things. So
Okay.
if that's and I'll do it very quickly. I'm just going to go in to see if I can navigate here. There we go. Okay, let me know when you can see that. Can you see?
Yeah, it's up, Teresa.
Yeah, it's there.
Perfect. Okay, I'm just going to minimize. So I just pulled Mississauga Halton, but you can certainly search. So if we went into, let me just see, Procreate, yeah. I can do Wellington, Waterloo. I can find another area. This one just is up. I'm just for the sake of time. But there's our 310-222 number for referral, and this is across the province. There's your health line. If you click on health line, that will also take you to the generic one, and you can punch in your own geographical area. So there's mechanisms on this particular site to help geographically, align you to where you want to be. This is Mississauga, our offices that we have. Compliments or concerns, we're always happy to have those. And then request for information. So if there was ever a time you needed chart information about a resident, provided the family, they might be looking for it as well. It's all through PHIPA, so there'd be a privacy request and a release, and a consent would have to be signed. We can't just automatically, there's a very formal process for that, but I do want you to be aware of that. Certainly if you want to join us, careers, I'm not trying to pull anybody out of their sector, but that is an opportunity who are partners. And then wait times. So if you go in there for wait times, just see, it's just coming up here. Then it'll talk about percentage that you get a sense of what people are waiting for in terms of complexity, wait times, in-home services. Like we just don't have wait times in the MH area. It may vary from geography, but I know Wellington, Waterloo, and Central West are pretty similar. I'm just trying to focus on those geographies. I know there may be people from other areas here today too. Okay, I'm just going to back up a little bit. So if you were looking for long-term care to navigate, you can go under here. It'll speak to you what I just shared with you in the slides about long-term care eligibility and admission, how to select in selecting a home, some key considerations around researching. These are the things you should be asking and looking for. And if you wanted to get information, this is telling about a request for information, you can go in here, take me to the form, and it'll help you connect with an individual, as well as ask the appropriate questions you need to know to help you fulfill your need for long-term care. And then if you need to find your local branch, right here, you can go in to navigate. It's very easy. The site has been recently updated in this last year, much better to navigate. If you do have any problems, please let us know. We're happy to bring that to fruition. I won't go into any more, I won't rob any more time, help you keep going. But thank you today for letting me present, and happy to, if you have questions, here, share them through Paula and the team or myself. Happy to help you. Thanks.
Thank you so much, Teresa. And yes, Tara has all of the information that will be emailed out to all of the participants today. Thank you.